pregnancy, trauma, and pain management on this episode of EM Unplugged. Let's go get it. Hey everybody, this is Charlie Swearingen. Myself, along with Greg Shadetree Cardiology, are going to be going through. This is one of our first educational offerings together. Really excited about it. So this is actually the first one we've recorded this way. So pretty fired up about it. What we're going to do is kind of break down what Greg went over step by step. Watch this video, and then even if you've already seen the video, the idea is that there's a way to get credit for it. If you're seeing this on YouTube, make sure in the description you go ahead and smash our site name at em.unplugged. This is our new little venture, and we're going to start giving CEs for all the stuff that you normally get. Now, some of it will have a little bit of a cost to it, and you can get things for pretty cheap that's very, very reasonable, or you can pay for some higher levels of subscriptions. But nonetheless, let's jump into the education and forget all that for just a minute. All right, so this was a great one on pain management in pregnancy. So let's kick it off and let's see what the big guy has to say.
Pain management in pregnant patients. What are your thoughts on pain management in pregnant patients? Do you do anything different for early trimester pain management versus late trimester? Well, yes, but actually no. So this is a whole can of worms, and we should open it. I can't tell you how many times I've been training a new person or a new medic, and they'll say, well, we'll have a pregnant patient with an acute injury that requires pain management. And they'll say, well, I can't give them anything. It's all pregnancy category C. And just in case you don't know, all opiates are in pregnancy category C, meaning the risk cannot be ruled out. But to be in category C, you can't have a documented, consistent history of teratogenesis either. Now, if you don't know what teratogenesis means, a teratogen is something that causes a birth defect. It comes from the combination of the words teratos, the Greek word for monster, and genesis, to create.
Dude, so that's why I love talking with this guy. He knows all the different beginnings and ends and all of the filler information that typically we skim through. He's got that all locked in. Somehow it stays in that cranium of his, and that's what he needs to really share with us. So, he's begging out early on saying, there's a difference between first and third, and then, which that just makes sense. I mean, and he's going to get into here in a minute, how the body kind of transforms a little bit, and some of the things that the trauma pregnant patient has to experience. But he does mention that there is a difference, that we got to take a look at it. So he kind of starts us off there. And then, of course, he's about to get into, he gave us a little bit of vocabulary here, right, with the teratogenesis, which monster. It's crazy. So basically, that's just a birth defect, right? So solid start. He can get verbose. And then, of course, I'm sure that if you haven't paid attention yet, this is Krebs cycle, S-Y-C-U-L. It's a little backwards there, but Krebs, cycle. So it's literally Krebs cycle paramedic. That could be a distractor. So now that we got that out of the way, let's punch it.
They were not very sensitive when they were inventing these terms. To be fair, the ancient world was a pretty brutal place, and this probably would have been the least of your concerns. Being able to get all bent out of shape over language is a luxury we have achieved by taking a break from killing each other constantly. So, have you ever been on a call and you had a pregnant patient that had a legitimate injury? I mean, let's just make it bilat broken femurs, because nobody can deny that. And then somebody says, well, I can give you some Tylenol.
Punch it.
When they taught you that Tylenol was better for bone-on-bone pain, they didn't mean jagged ends of bone scraping together. They meant like knees. Not broken ones, just achy ones. So is it safe to give a pregnant patient morphine or, say, fentanyl? Yeah, we're talking about single or a couple of doses here. We're not talking about chronic long-term use of an opiate. We're talking about acute pain management, enough to remove from distress. So case closed, right? That's all there is to it. No.
He always gives such a great spectrum of options, because medicine is just a practice, right? And truly, physicians have the greatest sphere. They literally have 360 degrees, where paramedics and nurses and other groups have just what certain physicians will let you do based on their scope of practice, and it's their scope. Whereas, a physician has a 360 degree scope. They have the full basket of medicine, so to speak. And of course, even physicians specialize and they get into their little scope. And so anyway, the point here is he's getting into the whole pregnancy category thing. And he mentioned earlier that every opiate is a pregnancy category C, but that doesn't mean we withhold it, especially, and we're going to get into in a minute what that means. So this is just a good setup for you to be thinking about it. What does pregnancy category C mean? And then of course, what do we do with it? And ultimately just kind of means that there's no evidence there's some evidence of harm. It's not a direct correlation, but there's some evidence, and usually it's an animal study. So let's take a peek and see. Let's just let him keep going. But this is really good. The whole point is it's okay to give these folks medicine, but that doesn't mean we shouldn't just willy-nilly, not consider anything else relative to it. And so we're going to give some medicine. So we need to figure out which medicine might be best, and that's what he's about to get into. And let's see. Let's see what he says now.
Don't forget the physiology of pregnancy and the new onset of all these hormones that the maternal body is making that most of the time lowers blood pressure, doesn't raise it. And that third trimester we were talking about, remember that dilutional anemia is a thing in the third trimester. If you take a pregnant trauma patient and administer too much pain control and end up making them hypotensive, the normal therapy for a normal person is to put fluid in the system. And of course, you want to be conservative in your fluid administration to any trauma patient, apart from the burn patient. But even then, we don't give as much as we used to think we should.
Okay, so he does these little spurs or these offshoots of the content. And again, it's all great stuff. That's why sometimes I'm sure I'm not the only one that watches him a couple different times. In the third trimester, as the woman has more and more fluid, mainly it's for a lot of reasons. There's a lot of fluid shifts that happen. It's trying to maintain that there's enough water to run the Krebs cycles, literally the Krebs cycles for the kid and the mom, for the fetus and the mother, but also to make sure there's enough fluid to maintain, basically help maintain homeostasis from a blood pressure capacity. But as we give a medicine, maybe not so much like fentanyl, but we give a medicine like morphine or Dilaudid or something where it has a little bit more allowance of dropping blood pressure. And that happens because when you give a narcotic, any of them, a little bit of histamine is released with each milligram. I'm sure there's a correlation there. But the point is, like, when we give a narcotic, a little bit of histamine release, and histamine causes vasodilation. That's what drops the blood pressure. And the reason why fentanyl doesn't cause that typically is because we give all those other types of narcotics and opiates we give in milligrams. We give fentanyl in mics. So we give just hundreds and hundreds of times less particles, and each particle causes a little drop in histamine. So we give so much less when we give fentanyl that a lot of times it doesn't trigger, especially initially or a second or third dose, it doesn't really start to trigger a drop in blood pressure until you've given a bunch of fentanyl or you've given it over a long period of time, at which case then some of that histamine, if there's more released than is taken back up or destroyed, then you can have that drop in blood pressure. Now, what do we do then? Like he's mentioning, okay, well, a lot of times if we have a drop in blood pressure because of something that we caused, and this is, take away the bleeding patient for a second. If you give morphine, drop blood pressure, we give a little fluid bolus, technically you give a little bit of pressure, and then, we could get increase in blood pressure. If you give fluid, isotonic crystalloid, to a patient who's pregnant in their third trimester, then we're putting them at more hemodilution and worsening potentially the problem. And what that does is spreads out all the clotting factors and that kind of thing, and that could be bad for them. So those are the kind of cases where maybe you consider, if you do give pain medicine and their blood pressure drops, that we give a pressor, or we throw some blood in there. Especially, some fresh frozen plasma isn't the worst idea in that case either, for your bleeding patients. So let's it's just beautiful points he's dropping.
With the patient that has dilutional anemia, you're already behind the 8 ball in terms of clotting factors in a trauma patient. And now you've just made a situation where they are hypotensive and you have to administer a decent amount of fluids to someone who really doesn't need them in the first place. Bleeding can be a legitimate concern in these patients right off the bat before you put anything in the vein. The last thing you want to do is over-administer an opioid analgesic and have to pump them full of more fluids while they have a risk of bleeding. And every pregnant trauma patient has a risk of bleeding. Whether you can see it or not is irrelevant. You also need to be considerate of the conditions that can produce traumatic labor. A body going
back. He's spitting total truth there. Bleeding can happen for a lot of different reasons. Where the placenta sits, the condition of the placenta itself, the what's going on upstream. There's a lot of, if pregnancy, if delivery begins, there's a lot of reasons why this could happen. So, if you have a shocky patient, right? Shock index is if that heart rate is bigger than your systolic blood pressure, then we need, and of course the other signs of shock, altered mental status, of course tachycardia is there, potentially later down the way, hypoxia, where we're not delivering tissues very well, weakening or absent radial distal pulses, all the good stuff. And then of course a trending blood pressure down. Those are the patients that we need to make sure that we do something about. Now, that doesn't mean, the reason we're getting deep into this is that doesn't mean we should give them pain medicine. But anytime you give a medicine, you should be thinking, okay, I'm going to give this medicine. What's the worst thing that could happen with this? Narcotics, we drop the respiratory drive, and some of them can drop blood pressure more precipitously than others. Okay, so then we need to be ready to bag and ventilate and potentially drop an airway. Okay, we also need to be able to fix blood pressure. So how do we do those things? And so, of course, simple bag valve mask ventilation, you could drop a rescue device, you could RSI and intubate. So if that's the case, if that's your, wherever you lie on that spectrum, be ready to do those things, right? That without getting too deep into, take away from my man's thunder here, know how to do those things. For blood pressure, for the EMT, you can raise their legs, and y'all don't come at me with that stuff. In the end, raising legs can give them about a unit or two of blood dropped into the core. I'm not saying put them Trendelenburg, but I'm saying you can raise trauma patients' legs. To make sure we get other groups there. AEMT and a paramedic can start an IV, give fluids potentially, and the paramedic for sure could give fluids and blood if they have the blood available, and then moving on from there. Pressors might be another option too, but just fix the blood pressure. Work on fixing the blood pressure, and be looking for signs of bleeding. It's a beautiful thing he's saying.
Through the process has a risk of bleeding. Whether you can see it or not is irrelevant. You also need to be considerate of the conditions that can produce traumatic labor. A body going through the process of gestating another human being will hit the abort button if it encounters a serious enough injury. Now you may soon be delivering a baby with depressed respiratory drive because of the opiates you administer.
Okay, this is another layer. All right, so just back up. Let's think of a 10,000-foot view. Where we're talking about, do we give somebody with bilateral femur fractures who's pregnant in their third trimester, we give them pain medicine? Well, we don't not give them pain medicine, pardon the double negative, because of the fact that they're in third trimester and it's pregnancy category C. A little is not going to go that far. However, what if the dose that we get, affects them very sensitively, and they drop blood pressure? All right, let's say they keep breathing, but they drop blood pressure. Okay, we need to go fix it. Thinking about maybe a pressor over fluid is a good thought. Thinking about if they're bleeding, blood over instead of isotonic crystalloid, and maybe if you have, packed red blood cells, if you don't have whole blood, but you have packed red blood cells and liquid plasma, maybe liquid plasma pops in first, or at least at the same time. The idea there is if the thought process of they're hemodiluted and that low blood pressure, instead if you do give fluid, then that's the next thing they need. They're probably going to need some clotting factors potentially. Now, typically in the hospital, they run the test, they run the measurements, and they figure out do they really need it or not. But you can be in the field, if this is something that's available to you, any level in there, that might be something to consider, is to give plasma with packed red blood cells if you have the option, or whole blood. Those would do the same thing, or not do the exact same thing, but those are in the same category. But it's really, really interesting thinking through. So then the next thing he brings up is, okay, well, And now what if the patient delivers? Because the body can handle so much stress, but the pregnant patient's physiology is very sensitive to things that could thwart both the baby and the mother. Said as elementary as I possibly could say it. Shade Tree is so incredibly smart, and he does explain things really well. I'm a redneck from Mississippi, and I get even simpler because I need to make sure I understand it. In the end, if the pregnant patient's body physiology thinks that both mother and child are in danger, it will abort the child. And I think somebody in the comments, right, oh, that's a bad choice of words. But that is the exact choice of words. It's spontaneous abortion that the body goes, nope, we're done, we're out. We're never going to put mom at risk, and it gets rid of tries to get rid of the fetus. That gets down a whole nother, education potential of discussing, all right, what do we do if water hasn't broken, but mom's going into labor? Do we stop it or not? So I think that I'm going to pitch to him, and we do one of those, and we do these kind of as a series. So but his point of now the baby's delivered. Let's say the baby's delivered, and it comes out, it's not breathing. Well, that's because it's just opiate. Right. And so a couple of ways to think there, like if it can be dangerous to give Narcan to a newborn who's under the influence of an opiate, especially if mom has been using. Probably not as bad as if we just gave it and the fetus is just now succumbing to opiate overdose because of what we gave. A lot of times you might not know that. Maybe you get a good history. You're convinced that, like, I don't think mom's a user, but that goes into it too. And so the whole point is what he does a good job of is trying to explain to the rest of us, like, our medicine isn't tunnel visioned. There's all these other things to think about. And that's honestly, when you think about it, what makes doctors so fantastic is they've trained their medical or their clinical peripheral vision is so broad. That's where, like, for us as paramedics or flight nurses and flight paramedics, or even EMTs or nurses on the floor, the idea is when you see a good physician and they're willing to teach every now and then, ask those questions, because all you're going to do throughout your career is hopefully broaden out your clinical periphery so that you don't miss something that is either major or minor. You're picking up those gems, and this is like a very, very important piece, and really the thing that if you're doing that more often, then guess what? You're not going to be as burned out, because you're going to be constantly learning. It's when you sit back and you think, I don't need to learn anything as much, or I don't want to learn anything as much, and you start getting rusty or complacent, and then something happens. You start getting pissed or whatever. So I don't mean to go down that rabbit hole, but this is why it's important to constantly be asking questions, so we don't just think, hey, do we give this pregnant patient with bilateral femur fractures, do we give her pain medicine or not? It's not just that. It's, all right, we do, what happens, what can go wrong, and then how do we fix it? Okay, then of the two or three things that could go wrong and the things we could fix, then what are some other things that could happen later? And so if the baby's delivered, the baby's drunk on a narcotic, then what do we do? And then thinking through that process is going to open up that clinical periphery.
This isn't to make you afraid. This is to make you cautious. When it comes to giving opioid analgesics to an acutely injured pregnant patient, use just enough to do the job.
Hashtag truth.
And be patient. Give your interventions time to work. In a normal patient where I'm going to administer fentanyl for a traumatic injury, I'll probably up that fentanyl every 5 minutes until I get pain control. Those intervals will be significantly more spread out in the maternal patient. I want to give this medicine time to work, to get into the cells, to get into the brain, and to do the magic I want it to do. And I need to give it time so that I do not over-administer these analgesics, because it can create a problem of huge proportions if we take it too far. We don't want that. The agency doesn't want that. The patient doesn't want that. And the baby doesn't want that. So just be conservative and be patient in between the intervals in which you would give this medication. And when in doubt, call a physician. It is understood that you don't do this every day. Or if you're a new medic, it's understood that you haven't been doing this very long. Calling for something like this and wanting to speak to a physician and saying, hey, I just want to consult with you because I want to do this right, that should not get you any hate from the ED or from your medical director. If I were your medical director, it would make me happy that you were being cautious. Medical directors don't like it when you call them for every little thing, especially if that every little thing is something clearly outlined in your protocol. But most EMS agencies do not have a clearly outlined maternal pain management protocol. And most of the education in paramedic courses is lacking in these special populations. Calling somebody and getting
in the end, like there's some things that you have to think through, and I think this is what makes this a very interesting topic to really consider, is because what we've gone through so far is, do we give the third trimester trauma pregnant patient pain medicine? And now we're thinking, okay, if we do, blood pressure can drop, their respiratory drive can drop. If there's too much extremis, then the patient could deliver the baby. The baby, when it comes out, might be drunk on opiates. Oh my gosh, all these things. Just be ready to fix those, right? And then his point here is, if you need to call somebody, call somebody. I mean, this is the type of, these are, and I've flown for essentially 10 years. Since 2005, I took a little bit of time off, but the idea is I've flown a bunch of patients, and I've done a bunch of stuff in OB, a lot of OB patients. A lot of those times, especially when I'm doing something that's critical or advanced, I'm on the phone sometimes like, hey, this is what I got. They're about to go into, they're in labor, no water has but broke yet. I want to give mag. I'm going to start it. Do you have any questions? Or the more important one was the time, or the couple times that I've had to call and say, the water has broke. You don't want to really stop labor then, because it's coming, and so but you can slow it down sometimes. And I would never do that on my own. I always do that with the discussion of physician. And there's a couple times we actually did put them on mag, slow them down. We're 30 minutes away, and then they complete C-section later. But nonetheless, he's totally on point here, and I just wanted to make sure that we're keeping things in perspective.
Some advice while you're waiting to earn enough experience to have a good handle on this is the mark of a good provider who doesn't have too much ego. Now, always obey your local protocols. Whatever they say, there's a reason. It's backed by a physician, and that physician knows a lot more than I do. But in 20 years and 9 countries, I've not met a physician that was unwilling to give an opiate analgesic to a pregnant patient with, say, a broken leg. They're not going to put you on months and months worth of morphine for any old thing. But to take you out of distress, especially in the third trimester where there are a litany of problems of letting distress continue, they're usually on board with that. Now, if you, your friends, or your agency are lacking in training like this, why don't you talk to your medical director or your training officer and say, hey, you know what? We would love for you to put together some specific material on this. After all, we do have to have a couple of hours of special populations in order to get recertified anyway, so it's not like it's a waste of time. You can always send this video to them, and that is much appreciated. But the real thing is, you want training boots on ground in your agency, by your training officer, by your medical director, so that you can continue to be an extension not only of your medical director's hands, but of your medical director's brain. And in the end, that should really be the paramedic's goal. What I want is for my medical director to look at me and go, I would have done everything you did exactly the way that you did it. You want them to be comfortable with the autonomy they have given you. The only way to do that is to be well trained, because most of your medical directors are going to be most concerned with, did you obey the tenets of emergency medicine as safely as you could? Some tenets of emergency medicine that would happen in the ED are not smart to conduct on an ambulance where you're so far away from external sources of help or greater amounts of equipment that may be needed to manage a patient if things go wrong. But in the conditions where you can do everything that is needed, should the intervention cause an adverse reaction, what you want to do is stick to the medicine, because that is the medicine that your medical director wants you to practice, so to speak. If you're not taking steps to learn this stuff, start. And if you're not taking steps to learn the proclivities of your medical director,
Dude said
start.
proclivity. Love his vocabulary. Solid. Go get that training, guys. Seek it out. It's in a myriad of books. They're all over the place. There's all this kind of stuff. If you something that you want us to specifically go after, make sure you drop it to his page, my page, or our new EM Unplugged page. Make sure you're dropping those comments.
One thing you will find very quickly is, as soon as your medical director feels like you would do exactly what they would do because they've spent some time training you, your autonomy, authority, your ability to do procedures you otherwise wouldn't be able to do, it's going to explode because of trust. Now, I know that as paramedics on land, especially, we feel like everything has to be delineated in black and white and it must be perfect and written out so that we can never get in trouble. But if you have a good relationship with your medical director and you establish that trust and that rapport, you would be very, very surprised at the things they expect out of you at that point. And it's actually pretty nice because then you can do the things your patient so desperately needs. It's a win-win for everybody involved. And that condition's no different in the pregnant patient. So if you need to study on this, please do. If you want more videos on it, please ask. But there is no substitute for having your medical director and your training officer train your agency, or calling somebody to come in and do that training so you guys are well refreshed. Hit me at the Gmail if you're interested in that. I'm happy to do that kind of stuff. I can only work on so many people with 2 hands. But if I can train a bunch of brains, I feel like I will have made a greater contribution to the effort that we all are working on, which is the easing of suffering. And should you ask me to do something like that, I am fully prepared to send all materials to the medical director ahead of time to get their stamp on it. Whatever it takes to make good medical training happen, just count me in. Hey guys, I hope you like.
So he's going to also now send, because this is another good thing about Shade Tree is that he edits. He goes through. He's watched his video and he realized he needed to say something and really hammer it home. So let's let him finish this last minute of the video.
Take a moment to talk a little bit more about pregnancy category C. Now, usually in pregnancy category C, animal models have shown a significant risk to the fetus. That is, of course, not a guarantee that will happen in humans, but it cannot be ruled out. Hence the verbiage they use to describe it. It is definitely worth your time to research your pregnancy category.
Pregnancy category C ultimately says it has caused harm to animals, but that doesn't always mean it translates over to us. It means it could. And especially, does it mean it'll do it in a single 1 or 2 doses? I mean, likely not. However, it's, if it happens in lower doses earlier on, right? So if it's in the first trimester where things are first and second, where things are really beginning to take hold and they get a couple too many doses of something, I mean, that makes sense too. So he's pitching, like, make sure you research it, you go through it. And that's kind of what he ends on. This is a great video. Getting into a couple comments, I wanted to mention, of course, first off, Krebs cycle. He did have that on his hitch right there. Somebody says, chasing blood pressure by pumping fluid and increasing coagulopathy. Are you practicing any type of permissive hypotension with this? Or, his response is, depends on the level of hypotension. So the only idea here is the permissive hypotension, like in the trauma patient, in the pregnant patient, if they're in trauma, that's typically the people that we, no matter what their SATs are, we usually put 100% oxygen on them, because getting oxygen to us, to our cells, air goes in the mouth, down the bronchial, to the bronchioles, past alveolar capillary membrane, onto a red blood cells, pushed around to the tissues, offloads into a tissue, finds a cell, finds a mitochondria, gets inside the mitochondria, and prevents acidosis from happening by being the final electron acceptor in the whole metabolism game. Well, in maternal and fetal circulation, it's got to go into the bloodstream, around to the placenta, offload across the placenta, find a red blood cell, get pushed around to the kid's different tissues. And so it's just a whole nother series. So typically they get a lot more oxygen, and in that same kind of capacity, typically there's a bunch of us who are way more, this isn't the patient we want to be permissively hypotensive at, but we also want them to have blood. We want them to have the right oxygen carrying capacity for the same reason. So, but again, if you drop blood pressure, I wouldn't just let that blood pressure be low. I would do something. I'd either give a pressor, which again goes down the rabbit hole. Like, okay, could that where are the pregnancy categories with that? Going down a different rabbit hole. But you get the blood pressure up, and maybe we get blood plasma. Plasma is a great volume expander. Plasma is like throwing a colloid into the vasculature. It's thick, big molecules, proteins, and it pulls water from the cells into the vasculature and holds it there, right? So it's got a hold to it. It's got an oncotic pull to it. And so a really, really cool thing. But the big picture here is I'd be real careful with permissive hypotension in the pregnant trauma patients. And we'll get some backup on that as well. All right, let's see. Somebody hitting off TXA in pregnant trauma patient. So the thing that I mentioned somewhere, this is where TXA was actually born, was in the in OB specific. I say born on purpose. This was born in the OB patient in postpartum hemorrhage. So it's safe to use, very, very safe to use, and that's it's the internal tamponade, right? If we have an outside bleed, we put pressure on it. Well, that TXA kind of acts as a somewhat of a metaphorical inside tamponade. Some other good stuff here. People talk about freaking out with all these patients. A lot of people are real kind about what's going on. Overall, the message here is you can give pain medicines. It differs from the first trimester to the third trimester. If you're going to give it, you need to know the dangers. If you're going to give those dangers, like at what level, if you're an EMT, if you're advanced, if you're a paramedic, if you're a nurse, if you're a flight nurse, if you're a flight paramedic, anything and above, how are you going to manage the dangers of the medicines that you're giving, and then be ready, to do that and constantly try to be learning and get further down this. This should be a kickoff point. And what we want to make this also for everybody is that this is our, if you're seeing this free on YouTube, make sure you click the link in the description. It'll send you to get access for pretty cheap. It'll be, a couple bucks, maybe a couple, $3 to $5 in that ballpark per each one of these, if that's something you wanted to do, but you get a whole hour of CE. And you actually get tested on this and a little bit more education, a little bit more stuff on it. And so that's the idea. Hopefully you guys enjoyed this. Let us know in the comments what you think. If you need something else, if you want to consider another topic coming up. Until then, from Angry and Shade Tree at EM Unplugged, thanks for joining us. See you next time.